Graham, have I talked to you on the phone before?
Maybe. I think your voice sounds familiar.
Yeah.
Yeah.
Sometimes if I hear your voice, I'll know. How long have you been with the paper?
Since August. I think Jacqueline is out today, so
Okay.
she would typically be here because she's our health reporter. But
Okay.
so you'll have to take it
But
easy
we're
on
thrilled
her.
that you're here.
What do you usually do?
The prison system.
The what?
The prison system.
Oh, yeah?
He's been busy lately.
Well, you've probably been doing stories on how the technology didn't work.
Right.
Yeah, that's what I was working on.
All right. Okay, let's go ahead and get started. Thank you very much for joining us today. Welcome to OU Medical Center, part of OU Medicine here on the Oklahoma Health Center campus. We've got some really exciting news to share with you today, and actually some show and tell that I think you're going to appreciate. It's the world's smallest pacemaker, and it was recently implanted in a patient right here at OU Medical Center. It was the third time such a device has been implanted in the United States. And the person who has been leading up this international research study is from the OU Medicine Cardiovascular Institute right here on campus as well. And he's heading up this worldwide study that's going to take a few years, and he can explain that in just a little bit. But we're already seeing some exciting results as a result of it, and it's Dr. Dwight Reynolds, who is also the chair, the section, let me say that again, he is chief of the cardiovascular section of the Department of Medicine here at the OU Health Sciences Center. So go ahead, Dr. Reynolds.
Great, thanks, Scott. Well, what we're here to talk about is this new technology. It's a pacemaker. It's a self-contained pacemaker, and I don't know if we've shot well enough for you to see some comparative sizes, but this is actually the pacemaker.
Can you hold that up just so in your hand?
This is the pacemaker here that is the new exciting small pacemaker, and it's exciting for more reasons than just being small that I'll talk about here in just a second. But you can see it in comparison to an older model of pacemaker, and actually this new model of pacemaker is more functional and will last longer than this older one. And you can see it here in comparison to some coins. The pacemaker is a device that we've had around since around 1960, and it's designed to make the heart or to keep the heart from going too slowly. That's really what the pacemaker is made to do. It functions when a patient's heart slows down too much, and typically has the occurrence of symptoms that are associated with too slow a heartbeat, and those symptoms can be things from just being fatigued, from being short of breath, having chest pain, dizziness, and even loss of consciousness. And so when individuals need a pacemaker, historically what we've had at our disposal, devices that work very well, such as this one, that we typically implant under the skin, typically, though not always, up in the upper chest area, in a small pocket that we surgically make, and then attach the pacemaker itself with the circuitry and the batteries that are contained inside the pacemaker to wires, either a single wire or multiple wires that we thread through the veins that eventually enter the heart. So we'll make a puncture, thread the wires down into the heart, attach them to the heart muscle wall, the inside of the heart muscle wall, although there are pacemakers that can be attached to the outside of the heart as well. So sew it up, test it and sew it up, and that's about all there is to it. The disadvantage of that is that it requires a surgical procedure. We typically have some problems, or we can have some problems with the pacemaker wires themselves. The human body is hard on the materials that are used to make the pacemaker wires. We actually call them leads. the leads can be damaged. And the other significant problem, the other two significant problems that we see with these wire-based or lead-based pacing systems is infection, and when people become infected with these devices, the entire device, including the wires, have to be taken out. And finally, the veins themselves can occlude, can stop up. They can become stopped up with clots and other material, and it makes access more difficult for future devices. So the new pacemaker, this one, we implant through a catheter that we insert into the femoral vein that courses through the abdomen and down the legs. We insert a catheter in the groin area, and through that catheter, attached to this pacemaker, we push it up using X-ray up into the heart and position it in a particular place in the heart, deploy it, test it electrically to make certain that it's doing what it's supposed to do, and then we let go of it. It has a tether on it that we cut, and the device, the entire device is then implanted attached to the inside of the heart muscle wall. If we have to move it, we can capture it with some tools that we have and move it, and hopefully we won't have to be doing that very much.
You know what, can you talk a little bit about, these are, I mean, it's basically an electrical device, correct? Because the heart is electric, I mean, it basically has an electrical rhythm, correct?
That's correct.
So what this is doing is sending an electrical signal to the heart?
It is. There are electrodes on the pacemaker, just as there are on pacemaker wires that we would use otherwise. Contained within this small pacemaker are the batteries required to stimulate the heart. We think this thing's going to last for somewhere between 7 and 10 years in most people. So the battery's there, and the electrodes that allow the electrical circuit to occur are there. What it's missing are the wires that connect to the much larger device. And the reason we've been able to do this is we've actually been talking about a device such as this for almost 30 years. And what's happened is that the circuitry technology has gone from mini to micro to nano. So the circuit boards themselves have become a lot smaller, and our battery chemistry's become a lot more efficient. So the battery itself doesn't require as much space to generate energy over a long period of time.
I know people with pacemakers, and I don't know if this is still true anymore, but there used to be warnings like around microwaves and around other things like that. Are there any issues with something like this at all?
No, we don't know yet about. We have some confidence that these devices are going to be MRI compatible, but we don't know that yet. But as far as microwave ovens and electrical signals coming from other equipment, we don't feel like there's going to be any interference with this. Now, I have to say that we're at the early stages of this technology. Worldwide, we've had over 60 implants. Less than a third of our implants have been here in the U.S. Most have been in a variety of countries in Europe. And so we're in the process now of doing a long study, a study that's going to take several years to complete, and 700 plus patients. I can honestly say that we're having great success with it so far. We have a number of patients that are now out 3 months or longer, and a lot that are out a month, and the success is very encouraging.
Tell us about the case that you had here.
The-
How have the results been so far?
We've just completed his 1 month. The patient that we have here at the OU Medical Center, we've tested his device at 1 month after implant, and it's working beautifully. And he's very happy with it. I won't go further than that, but I think he's.
Well, he spoke to us and he said he gave us, he's shy and therefore did not come today. So I apologize to the media for that. We both talked to him on the phone. And I did include some comments from him that he gave me over the phone. And he might be willing to talk to some people over the phone. So we'll ask him. But he didn't want it to be about him, is what he said. It's not about me. He's a little bit shy, but he was very happy to be back to his normal activities.
And the truth is, it is about him. It's not just about him, but it's the promise that this new technology has for him and for so many patients otherwise. The ability to have a device such as this implanted rather than the more complex implant procedures that are required for standard pacemakers.
You might talk about one thing that he mentioned to me on the phone is he was thrilled to have it one day and be home the next.
Right.
He said that I guess he was kept for observation and then home the next day.
That's exactly what we did with him. Now, I will say honestly that's what we do with most patients that we implant pacemakers in. We let most people go home the next day. We believe that over time we'll do these implantations with this device and let people go home the same day without too much trouble. But there are also a lot fewer restrictions that we place on people with this device than with more standard pacemakers.
The ability, the other thing, he loved the idea to not have the incision and something visible in his chest.
Right.
Is something he talked about.
There's for external marks, there are none. To find this, you'd have to look at a chest X-ray to see it, and the reality is, I don't know how well you can judge this, but it's about the size of a .22 bullet. So I can imagine that there'll be a lot of radiologists that'll look at X-rays with this device in the heart and think, that's interesting.
It might be the first thing that crosses their mind. You know, and I think about how this makes individuals, you know, when you travel and you have a pacemaker, a lot of people carry a note with them because they have to go through all of the equipment at the security checks. I would imagine with something like this being so small.
We don't think this is going to set off. We're going to be sure that people have cards that will get them through travel testing devices. But I don't think that we have too much concern about that.
It's smaller than a typical watch. So much smaller than
Yeah.
the metal that would be in.
Yeah, I think you know, this is an early iteration of the device. I don't know that we're going to see a lot of downsizing over the next 5 to 10 years from this size, but many of the pacemakers that we implant today, we implant in multiple places in the heart, and right now we're somewhat restricted to implanting this in one chamber of the heart, and a particular chamber of the heart. It is unquestionably a goal that we want to be able to implant it in at least 3 chambers of the heart. And there are challenges about the communication of these little pellets in the heart. We think one of the questions we've gotten not infrequently is, well, what happens in 10 years when it wears out? It's amazing how little space this device occupies inside the heart. So we anticipate being able, without too much difficulty, to just go right next door inside the heart and implant another one, and even more. What will happen, we think, with time is that the heart has a natural, the heart and vascular system has a natural ability to coat foreign bodies, whether it's heart valves or stents or pacemaker wires. And we think that over time these are going to get completely covered up and be just part of your body.
Is this for anybody, or are there only certain individuals with certain types of rhythm issues who would be a good candidate for the study and implantation of this device?
That's a good question. Right now, we have inclusion and exclusion criteria for it, and it's going to be very restricted in this study to specific kinds of patients. And most importantly, it's going to focus on patients for whom a single chamber pacemaker would otherwise be appropriate.
How long does it take to actually, I know it's a catheterization procedure, it's done, I guess, in the cath lab, is that where this is done?
We do the implants in the cardiac catheterization laboratory, just like virtually all pacemakers are implanted today. But the implant of this, the first one we took a little bit longer because we had a lot of people around, and we were dealing with a lot of first events. But the implant of this I can easily see taking 10 to 15 minutes, and that's from the time we puncture the vein to the time we remove the catheter from the vein, and that's certainly less than it would take to do the standard procedure.
How long is the study? I know you said how many people you hope to enroll in the study, and how long are you going to follow them?
We're going to follow patients for 5 years, and we anticipate enrolling 720 patients, and they'll be studied at regular intervals. When I say studied, testing the pacemakers to make certain, and we do that with patients anyway, to make certain that it's functioning the way we intend for it to. I think that while there are going to be several interim analyses done to determine how we're progressing statistically with the test, but we anticipate this study is going to last a good five years or more.
Do I oversimplify what a pacemaker does if I say that it's basically just repacing? I mean, it's called pacemaker. It's repacing the heart, so the heart's maybe beating too slowly. This just tells it to speed up.
Yep. That's a very good way of putting it. And I think I don't think that is an oversimplification. In some patients, the pacemaker will function for every beat. That when there's no underlying natural heart rhythm, the pacemaker will take care of that. In many people in whom we implant pacemakers, there is at times a need for that kind of support, but at times the patient's own heart rate comes through, and that will turn the pacemaker off, which is a good thing.
They're actually detecting what's going on. That's what I almost think it's just a set rhythm, but really it's listening to what the heart's doing.
Right. And so the other thing that I should mention is that there are sensors, 3 sets of sensors in the device that detect motion. And so with exercise, the device has the capability of going faster or at rest slower to more closely mimic the natural way your own heart works.
What's it made out of?
It's a titanium alloy. There's a special lithium battery inside. There is, can't see it very well, but there's an electrode at the tip that's in contact with the heart. There's another electrode further back. That is the other electrode in the electronic circuit. And then there's the nano circuitry inside. It's fairly standard stuff now.
Did you say there was a coating on one electrode?
There's for years we've used small plugs of steroid to reduce the inflammation that can occur when the electrode comes in contact with the heart, and this contains a steroid that elutes over a period of time.
How did you personally get involved in this international study?
I've worked with the company that developed this for 3 decades now, and as I said, we've been having conversations about this for that many years. I'm not certain that that has anything to do with why I'm involved with the study, but many of the people, many of the investigators that are participating, we have now 8 centers that are active in the U.S. We plan for a number more. Many of the international investigators are people that I've worked with over a long period of time. And the researchers, the research development people at the company are people that I've worked with in the past as well. So that's the way.
How far have you seen technology come, and I can't even imagine where we're going because things just keep getting smaller. And I mean, I even think about hard drives on computers, and now we can walk around with more than we were ever able to keep on our computer in our pocket on a little flash drive. And I assume the same thing is happening with medical technology.
Right. I think it's dramatic. The first pacemakers I implanted were probably 4 or 5 times the size of this one 35 years ago, and that was 20 years after the first pacemakers were put in. So just over the past 35 years, and certainly over the last 55 years, we've seen absolutely dramatic reductions in size. And the reductions in size are largely driven by technology advancements in the world of electronics. Moving from, obviously, we can't implant a device this size inside a heart. We can implant a device this size. The big differences in these 2 devices relate to this miniaturization of the circuitry and the increased efficiency of the energy that we talked about. A better lithium battery is part of the.
Well, and you're putting less stuff in the body, which to me would indicate you have less chance of the body reacting to, as you said, you were before having to run the wires, the leads from the pacemaker to the heart. You had more material, just frankly, that the body could say, hey, this isn't me.
Yep. And what I think an important piece of this, and we know this, we don't spend a lot of time talking about it, or probably I do spend a lot of time thinking about it, but the part of the pacing system that's most susceptible to failure are the wires. The hardware, the device, the can itself doesn't fall apart, isn't as susceptible to the movements of the heart, isn't as susceptible to the movements of our extremities, of the muscles in our bodies, and also not as susceptible to degradation, chemistries that can mess up pacemaker wires. So I think that we're eliminating the part of the pacing system that has the highest risk of failure, and that's the lead with this.
Actually putting the pacing right where the pacing problem is.
Right. That's exactly right. And I have no doubt that we always tend to think of the present as being where the technologies, we've come so far that we can now fly in airplanes and we didn't envision that there would be such a thing as a jet in the 1920s when we were flying around in airplanes. We didn't envision flying to the moon. Well, some people envision flying to the moon, but I really believe that we're not at the end of the reduction in size and the greater efficiencies that we're going to see with these technologies. And communication is a big challenge between this device and another implanted device inside the body. Not to talk about a pacing system, but we now have on the market defibrillators that don't have wires, that can be used for an entirely different purpose, but don't require wires that go inside the blood vessels. And so I think over time, and it's going to be time, we're going to see hopefully progressive elimination of the requirements for the leads. We're not there yet. We've got years to go, and we have to be extremely meticulous in our studies to make sure we're doing the right things. And we're doing this for patients. It's not for us as physicians. It's exciting for us as physicians, other healthcare workers, but it really is with an eye to improving the lives of the people that we serve.
This larger pacemaker, the small one will last 10 years. How long would you typically have one of the larger ones before you need to replace it?
This happens to be an older model, because when I looked in my desk drawer, I didn't have the newest one, newest model of one.
So you have the newest one. How long would you?
They'll last that ballpark
Around.
figure. Yeah. 7 to 10 years. We have some that last longer than that.
You mentioned the problem getting them to communicate. It never would have been the case today that you have two pacemakers in, correct? So this is a new obstacle you're facing, essentially.
Essentially so. Yeah. The communication occurs in the multiple location pacemakers today by having wires that all come to the pacemaker.
Oh, that's how they're made now.
Right.
You have more than one.
Right. So we might have as many as 3 different wires coming out of the pacemaker, going down through the vein and attaching to different locations inside the heart.
And I understand that the absence of those leads means that they can't be damaged and there's less risk there. You also mentioned there's less risk for infection. Is that because there's no leads, or
Right.
is that because of another reason?
Most infections of pacing systems are infections that occur in the pocket that's created underneath the skin, and others involve infections of the wires themselves. The bacteria can actually get inside the wires, and it's bacterial infections that we wind up having to deal with. When that happens, antibiotics won't clear the infection. So the entire system, I tell this story to patients when I describe the problem of foreign bodies and antibiotics not curing it. It's like getting a splinter under your skin. You can put local antibiotics on it till as we say in Oklahoma, till the cows come home, and until you get the splinter out, it's going to keep coming back, keep, as we say in Oklahoma, festering. So, but the other big challenge is the occlusion that occurs in the veins. We put the wires down through the veins, and the body says, you don't belong here. You're a wire. There's not supposed to be a wire here in this vein, and so we're going to wall you off. We're going to have clots around you. We're going to.
It shrinks that vessel.
It actually not insignificantly creates problems with venous occlusion. Now, I don't want to scare people to say, well, that could be a heart attack or a stroke. Those occur in arteries. Those types of problems occur in arteries, and we don't put these wires that we use for pacing systems in arteries. We put them in veins, and the body has a way of dealing with rechanneling the blood, the venous blood, the vein blood. So we don't have to worry about that part. But for example, if someone has to be on dialysis or has to have lines in for chemotherapy, any kind of IVs, it can be a real problem.
Explain how you get it. You mentioned that you use X-rays, but I'm still really curious how it actually travels from the femoral to the heart.
So it's there's a sheath that's like a large piece of spaghetti or a small straw that we put into, just by puncturing, not surgically, just by puncturing the vein that comes through the groin. That's called the femoral vein. That vein connects through a series of veins to the heart, get progressively bigger, sort of like a tree. And through that straw, we put a catheter that's a smaller straw through that outer straw that has the pacemaker attached to the end of it. You can't see it very well, but there's actually a little hole here where a string runs through and comes back out the catheter. We run it up attached to the catheter. So this would be like inside the catheter. We run it up. That's an Oklahoma term too. We run it up. We run it up through the outer straw, watching it on X-ray.
Oh, so you're actually physically pushing it?
Yes.
Okay.
Yeah. We push it up, get it in the right position. We have ability to maneuver the catheter that this is attached to until we can see exactly where we are inside the heart. We do what we call deploy it, and then once we're comfortable with the electrical testing, we let go of it, the string.
You mentioned so if that one stopped working, you'd like to have another artery that could start, you could put another one in another artery eventually. You could just leave that one there and it wouldn't cause a problem in the future?
We actually have the capabilities of turning it off.
But I mean, it won't cause blockage or anything?
No.
You just let it sit there?
No. As a matter of fact, it's interesting because it occupies very little space inside the heart itself.
It's got little hooks on the end that when you get up there close and look at it, you'll see these tiny little...
Here, you can.
And that's
Can you catch?
what actually holds it in the heart muscle. You see those little catches? That's what holds it in place.
It's even lighter than I thought it would be.
Those little whiskers on the end are made out of a material called nitinol, and they seem to be very secure in holding these in place. To date, we've had no dislodgements in the worldwide study, and we've been extremely happy with the performance of the device so far.
Is it cost effective? How much more would it cost the patient?
We don't know yet because it's currently because of the way insurance companies are dealing with it, or because it's not FDA approved. So
It's just only available through the study right now.
Okay.
yeah, so it's not on the market yet.
Now, if the doctor told me that I needed a pacemaker, and forgive me, this is probably a pretty basic question, but do I have alternatives? Are there other ways I could treat my symptoms other than having a pacemaker put in?
Typically, the answer for people who need pacemakers is a pacemaker. There aren't other great therapies that are alternatives. Sometimes we implant pacemakers in people who need them because of medication they have to take or need to take, and in some of those people, we can modify the medications and see if that takes care of the problem. But in most patients in whom we implant pacemakers, there is not an alternative.
Does shrinking it, given that, does shrinking it, are there any inherent risks that are greater in making it smaller for the patient?
Not inherent risks. And we're certainly monitoring all the different things that we've thought of in the course of the study. One thing that probably is true is that after a number of years of this being implanted in the heart, it'll be very difficult to remove non-surgically. We just don't anticipate needing to remove them. Currently, when
Can you explain why that is? What happens to make it?
like what happens in the veins with the wires, the body says you don't belong here. So eventually, with time, we expect to see, in many cases, progressive fibrotic material just covering a.
So you got caved in essentially.
Yeah, exactly. Yep.
So it kind of walls it off. The body says this is no longer, and it walls. It'll just create kind of a protective,
Right.
almost a protective wall
Right.
around the device. Okay.
And
I'm sorry.
no, go ahead.
I was gonna say, you were saying that there's one chamber right now that you can get it in, no problem. What's the problem that you're facing getting it into other chambers?
The chamber that we implant this in, the right ventricle, is especially amenable to this technology. We put most pacemakers that are lead-based pacemakers, wire-based pacemakers, we implant in the right ventricle. It's the right atrium and the left ventricle that we also sometimes put more conventional pacing wires in. This particular configuration isn't ideal, at least for the right atrium, and so we're already exploring the things that we need to do to make this small technology amenable for the atrium. It's possible that this device could be put into the left ventricle, and we do that in some patients now that we need to achieve resynchronization therapy with standard pacing wires. But this is not part of the study, and we won't be implanting this in this first pivotal trial that we're doing.
So this is like most studies. You look at, will it work this way, which is, I hate to say simple because it's not the most common application
Right.
of the pacemaker. So you want to see how well it works, and then if this works, then there could potentially be additional studies that are launched looking at other left ventricle or another
No doubt.
version of this.
No doubt. I think that everybody, no matter what your participation is in this, wants to start with small steps and then grow as we need to.
So it'll be at least 5 years before it's even close to available, though, right? You're going to be watching these patients.
Well, I'm getting old, and I'm hoping it's not going to be 5 years, because these interim analyses are going to be important for us to do. And I think once we and the FDA and the other regulatory agencies around the world are comfortable with it, but we have to be cautious about the science. We have to be cautious about the statistical aspects of the science, and that we do enough and follow the patients long enough that we have confidence that what we believe is going to happen is going to happen.
Those 60 that have it now, how long ago was the first one?
The earliest ones were implanted in December.
Oh, okay, so pretty recent.
The first the patient that we implanted here, gosh, a little over a month ago now, was the third patient in the U.S. And there were reasons, technical reasons that the U.S. didn't start as early as Europe. But we've got implants now in France, in Germany, in Hungary, in Japan, in Spain, in Belgium, in Austria. I'm probably leaving somebody out. We have plans in this study to implant in other European countries and in Malaysia, in India, in Pakistan. But everything really has gone gone beautifully so far.
Any other questions? All right, Dr. Reynolds, thank you very much. Appreciate it. Great job.
Yeah, thank you. It's exciting stuff.